Welcome to Your Healthcare. I'm your host, Dr. Lahav, and in this show, we discuss medical-related topics, issues, and things that are out there that would hopefully benefit your health. What makes you tick every day of your life, every minute of every day of every year? It's your heart. But how much do you know about your heart? What are some of the risk factors? How do you improve your heart condition? That is the most important part of your body, your heart. And how do we make it better, survive longer, especially as we get older, to really maintain that longevity of the heart in your chest that beats every day of your life? Today is a very important show and very interesting show. And if you would like to know how to make your heart healthier and last longer, understanding the risk factors behind heart disease, stay tuned, because we have with us today Dr. Clifford Kramer, expert in cardiology, who can tell you about your heart. I'm Dr. Lahav. Stay tuned. We'll be right back to Your Health. Welcome back to Your Healthcare. I'm Dr. Lahav, and in today's show, we'll discuss one of the most important parts of your body, your heart. Without your heart, essentially, it's what we consider biological death. But with your heart, your longevity can go on and on and on. But how much do you know about your heart, about the health of your heart? Today, with us, we have Dr. Clifford Kramer, expert in cardiology. Dr. Kramer, thank you very much for being with us here today.
My pleasure.
And I'd really like to jump right into it. This is going to be probably one of the most important shows that you will see, and you will learn about risk factors and things to make your heart healthier. So I'd like to really kind of go right into it. You know, your heart. Let's just start about, what is it?
So your heart, as you know, drives the body. And it's got to work right. It feeds all the organs. The organs don't survive if the heart doesn't get blood to them. So we like to think of ourselves as most important.
You're like the engine of the car.
We're the engine.
You know, as an orthopedist, maybe we're the body of the car, but the car won't run without the engine.
That's exactly true.
So that's actually, you know, very important, because you can live without a limb, without an arm or a leg, but you can't live without a heart.
That's true. You know, we have incredible ways to help people function better and survive longer compared with ages ago, when people died young, when we didn't have ways to keep the heart going. We have medications, we have procedures, we have assist devices, we have operations that basically have people living, functioning into their 80s without difficulty.
So having all this sort of armamentarium of things that we can do to make your heart healthier, let's really start at the basis. How do you know what are some of the risks that you have to having heart disease? How do you know if you're at risk for having heart disease?
Sure. I think the important thing to start with is you've got to get this sorted out with your doctor. You see your doctor, he takes a history. You go to your primary care physician, he talks to you, he checks you, he finds out if you have the important risk factors. And those are, number one, the worst thing you can do, and you don't need your doctor for this, is cigarette smoking. So if you smoke or have diabetes or have high blood pressure or have a family history of early heart disease, you're at risk. You want to have your cholesterol monitored, find out what that is, and then the risk factors that could be modified need to be modified. So you have to start there.
So smoking, diabetes, high blood pressure, family history, very important. And now you touch also on cholesterol. Now there's good cholesterol, bad cholesterol. There's also triglycerides that, you know, now it's really come into more of the blood work and lab work that people get. What does all that mean?
So what that means is, as you said, there are 3 points that are important. So if we talk about cholesterol, we talk about the good cholesterol, which is the HDL. And that's something you can either be happy your parents passed on to you or be unhappy they passed on to you. And if you have a good cholesterol that's high or elevated, it actually protects you.
And what is an elevated, or you want to have above what level of the HDL, the good cholesterol?
If the HDL is above 60, it affords you protection that somebody with a low HDL doesn't have. So if, for example, you have a very high bad cholesterol, this offsets that somewhat. The HDL, or good cholesterol, you can improve, but it's a bit difficult. So the things you're going to do to keep your HDL cholesterol as high as you can, other than have the right parents, is regular exercise, stay slim, and have a nice low body weight, and avoid cigarettes. So if you're overweight, you smoke, and you don't exercise, your HDL is going to be lower. You can bring them up, and even a drink a day.
So even if you exercise, now you're talking about more aerobic type of exercise? Or
Aerobic
weightlifting?
exercise, yeah. You know, isometric exercise, resistance training is great. No doubt about that. But the benefits to you cardiovascular-wise, or cardio, what everybody calls it at the gym, that's the important thing. And if you're going to lift weights, you can do it with aerobic training at the same time. You can move fast, do fewer sets of lower weights, move quickly from one to another, increase your heart rate, work up a sweat. If you just go to the gym and lift weights, you'll look good, but you won't be healthy.
So for some of the guys out there, you got to even it out a little bit.
That's right.
So you know, the first thing that's important again is it's your good cholesterol, or the HDL. What's important is being more lean, having a good diet, exercise, and hopefully having the right parents to pass down that trait.
You know, we should talk about diabetes here, because diabetes is an epidemic in the United States. And the type 2 diabetes is related to obesity and inactivity and eating poorly. And by eating well, losing weight, you can raise your HDL, and that's huge, and solve your diabetes and not require medications. So that's a really important point. There's something we call the metabolic syndrome, which has to do with diabetes, low HDL, and obesity. Sorry. We should change that to obesity. But it's this is what, you know, Americans are suffering more and more from as they get older and heavier and less active.
Yeah, actually, you don't see it as much in Asia and sometimes in Europe, because a lot of those individuals use bicycles to get from place to place. They do a lot more walking. Their diet is more grain-oriented rather than carb-oriented here. And it is a problem in the United States that individuals are getting heavier and heavier, and leads to a lot more heart disease and diabetes. It goes hand in hand with it.
Absolutely.
So now we'll talk about, let's go for the bad cholesterol.
Right.
So what do you do with a bad cholesterol, let's say that it is high? And again, what is a high number for bad cholesterol?
Right. So we look at the cholesterol in context of your risk factors. So if you're a young person, if you're 35, and you have no other risk factors for heart disease, even if you have a high bad cholesterol, or LDL, your chance of having a heart attack or stroke is very low. So if your LDL cholesterol is high, we generally treat it with diet. So what's a high LDL? Well, above 150. So if your bad cholesterol or your LDL is above 150, you want to make every effort you can to do the things that are important to lower it. Lean body weight, low fat, low cholesterol, low sugar, diet,
What about
regular
some of these,
exercise.
exercise, again, very important. And what about these, different diets that are out there now? People that get rid of carb altogether, and some of these sort of, like the Atkins diet that was,
Right.
fat-oriented diet to try to make the fat burn by only eating it. How do these diets really work for your heart?
Right. Well, people have a terrible time understanding this because it changes so much, and the studies give us different information. And just recently, we've noticed that by asking people to eat just low fat and low cholesterol, they've increased their carbohydrate or sugar intake. And the problem is that's created a new wave of diabetics because they're eating more sugars than they should be. So really it's about balance, and it's about caloric intake. It's not about eating one food group only. It's more about a balance between protein, carbohydrates, and fats.
So really your body does need all these things that the food really provides you, from sugars to carbohydrates,
Right.
to some of the fat as well, to dairy, to things like that. It's not that you have to eliminate one component of it and go on this diet. It's not sustainable for the body, and it's not healthy for the body.
You're right. I mean, it's really quite simple. I'll just tell you that almost everybody that comes into my office that needs to lose weight and do better tells me they don't understand why they don't lose weight, they don't eat that much. And I say, well, this is what you've got to do. You've got to count calories. Walking, moving around is good for overall wellness and health, but you won't lose weight. So if you don't count calories, and for a man that means eating less than 1,800 calories a day, and then I give the example of a bagel and cream cheese, which is 500 calories, just to put it in perspective for people. But the trick is, there are some simple things you can do. You cut out desserts, only one portion when you sit down to eat, and you restrict the pasta, bread, carbohydrates, things like that. In the morning, instead of eating bread and bagels and things like that, you eat grains and fruit. You change the food groups. It just takes a lot of willpower. We've all come to understand that because we all suffer from lack of willpower. But it's critical, and that's really what you need to do, and it's a tremendous change in your lifestyle.
And the vegetables component of your diet also can be increased. I mean, you can eat and eat and eat as much salad as you want, which is great, and that will
Absolutely.
be filling. Water is another important component.
Right.
Maintain your fluid intake that's appropriate. So all those things will help lower your LDL or your bad cholesterol.
Right.
Now a lot of people kind of get around, say, I want my cholesterol below 200. That's kind of the number that floats
Right.
around. So what does that mean? It's not just the bad or the good.
Right, that's a total number. And that was important when we used to think that medications for both HDL and LDL were useful. We now focus on lowering LDL, which is the bad cholesterol. So that's where we target our drug or medication approach. So the total number is dependent on, of course, the LDL, the HDL, and also the triglycerides. There's a formula. So, but the important thing to know is that medications do lower the LDL. And if you have risk factors, you need to do that. And if you have a problem with either blocked heart arteries or stroke or blocked arteries in your legs or diabetes by itself is such a huge risk factor that we recommend those people take these statin drugs to lower their LDL cholesterol. So the average young person whose LDL cholesterol is 160 or 170 without other risk factors, we don't recommend that they take statin drugs. We ask them to change their lifestyle, their diet, and drop their LDL, hopefully below 150, and hopefully 130 being a goal. If you have those other serious risk factors or combinations of them, we need your LDL to be even lower. So if you had diabetes or had a heart attack, I want your LDL cholesterol to be down around 70. And that usually takes medications. And the medications have been proven over and over again to prolong your life and prevent heart attacks. And the side effects are very minimal, despite what people often think and worry about.
Well, not, since you brought it up, some of the statin drugs, which, as an orthopedist, we actually do see because
Sure.
some people can't handle some of these medications that come in with joint pain or muscular pain.
Right.
And how do you sort of work with that for patients, let's say, are having difficulty with some of the statin drugs? What are some options that you have?
Right. So the most common problem is muscle aches, large muscle groups. People come in and they say their shoulders, their arms, their thighs, their legs, they ache. When you have a side effect from a statin, it's usually fairly constant. It happens to you all the time. It doesn't just happen when you exert yourself, though it can be worse when you exert yourself. And what we do often is we take those people off the statin drug for a week or two to see if their symptoms resolve. And if they do, we know that that's the problem. And then we try to use a lower dose because we know that it benefits them. Even if their cholesterol level is low, if they've had a heart attack, the statin prevents further heart attacks, even without lowering cholesterol. So we'll put them on a lower dose. We might try every other day. We might try 5 days a week. And then we consider switching them to others. There are 5 or 6 of them, and often we can find one. And we try really hard to find one. And sometimes, if we can find a combination that causes only mild muscle aches, we try to encourage people to take that and live with it if they've got a lot of risk factors, because we know what we're doing for them.
So really, the benefits of taking these type of medications can outweigh really some of the risk or some of the discomfort for individuals who are at higher risk for having heart problems.
Well, that's an excellent point because it's usually only discomfort. We can check a blood test, a muscle enzyme, to be sure there's no inflammation of muscle, which there usually isn't when people have muscle aches. And if that's normal, we don't have to worry that we're injuring their muscles by using a lower dose if they have some discomfort. And then the liver issue is another issue. And people tend to, everybody has an uncle or a grandfather who has a problem with something. And they tell their kids or their nephews, or I had muscle aches, or I had generally, it's incredibly unusual to have a serious problem with the liver or the muscles when you're taking these medicines. So we really push them hard. And you can't come off them.
So once you're on it, you're on it.
Because it helps you. And if you're 80 years old, you might say, I'm 80 years old. Why do I need these? Well, if an 80-year-old has a heart attack, his chance of dying is much higher than a 40-year-old. So we want to prevent heart attacks in all age groups. So we try to keep these medications on board.
And let's just complete the discussion by finishing with triglycerides.
Right.
That's also something that's really come about for patients that have high triglycerides. We're trying to lower that as well.
Right. The triglycerides are stored fats, and they're complex carbohydrates. All the things that everybody loves to eat end up as stored triglycerides. And the triglycerides are lowered by regular exercise, having an ideal weight, and avoiding, sugars and carbohydrates. And we don't treat them as aggressively as we used to anymore. We focus on the LDL. Diabetics, overweight, commonly have high triglycerides. If the level is very high, greater than 500, normal maybe being up to 150, we treat them because we're worried about their pancreas, which can be affected by triglycerides. But we don't we try to get people to modify their habits. That's the most important approach to them.
So really, the common thread that I see here really on the risk factors, talk about cholesterol, triglycerides, is maintaining a lower body weight or body mass index,
Right.
having a more healthy lifestyle, exercise, controlling diabetes, sugars,
Right.
sugar level, and essentially, again, really changing your way of thinking about caloric intake and more kind of aerobic type of exercise to help lower triglycerides, the bad cholesterol. The good cholesterol, part of it seems to be that you're kind of born with a certain level you're going to reach. You can work on it a little bit, but you're going to have sort of a ceiling at some point.
That's true.
So that's really the first main point that we want to bring across. And again, the common thread that comes through here regarding a comorbidity is diabetes and really weight. And those are two things that are controllable and can be done something about by seeing your physician. And that's really sort of the gatekeeper that will analyze you and see if you are at risk, which then sends you to a next level professional like yourself, Dr. Kramer. Stay tuned and we'll continue discussing about your heart. This is Your Healthcare. I'm Dr. Amit Lahav here with Dr. Cliff Kramer. Welcome to Your Healthcare. I'm Dr. Amit Lahav, and today we're discussing your heart health with Dr. Cliff Kramer. Again, Dr. Kramer, thank you very much for being us. And really in the first segment, we touch about, the cholesterol, the triglycerides, diabetes, family history, and obviously maintaining a good, healthy lifestyle. Let's kind of move on also. One of the other big risk factors and kind of goes hand in hand with your heart is high blood pressure, what we call hypertension.
So, hypertension, I'll start off by saying we call it a silent killer for the people that are watching that have high blood pressure and feel fine, because generally you feel fine. If you don't go to your doctor and get your blood pressure checked, you will never know that you have high blood pressure. And that's very common. People don't want to see doctors. They don't have health insurance. They are in denial. They don't want to know what they have to do to make themselves healthier. So you've got to get your blood pressure checked. And if it's elevated, what do? Well, the first thing we do is, we look at it in different categories.
Yeah, actually, let's first break down the blood pressure.
Right.
There's a high number and a low number.
There's a high and a low. The systolic is the high number, and that measures the blood pressure in the arteries, if you will, when the heart is pumping. The lower number, the diastolic, measures the blood pressure when the heart is relaxing. So they're both very important. We would like to see everybody's blood pressure no higher than 120/80. 130/80 is a good target. I'd like to talk about the elderly, 80 and above, for example, who don't tolerate low blood pressures as well. And you know this in your specialty because every day you see people who fall. And a lot of these people fall because we lower their blood pressure too much, and when they stand up, because they have very calcified arteries, the blood doesn't reach the brain. They get dizzy, pass out, or fall. So we don't want the elderly to have that low a blood pressure. So if an elderly person's blood pressure is in the 140s, that's fine. That's acceptable. And that comes from a lot of new research in that area as well. So if your blood pressure is 130 over 80, that's ideal. You know, mild hypertension would be 140s and 90s. Moderate hypertension would be maybe 160 over 100, and severe hypertension would be 180 over 110, that kind of thing. So most people walk into your office, and there's something we all are familiar with called the white coat syndrome. They're nervous. Even if they're not feeling nervous, it raises their blood pressure. Adrenaline raises blood pressure. So if your doctor says you have high blood pressure, take a medication, what he really should be saying is you have high blood pressure, watch your salt, lose weight, exercise, and we'll check it again in a month or two. And you do that over 6 months if your blood pressure is only mild or moderately elevated to sort out, do you have high blood pressure or not? And if you have what we call the white coat hypertension, we have people take their blood pressure at a pharmacy where there's nobody with a white coat, or get an automatic cuff at home and do it. And that is really quite useful in sorting out whether people really have high blood pressure or whether it's related to situational issues.
And now, if you have very severe high blood pressure,
Right.
Very severe, and you've
Right.
never really monitored it at all,
Right.
Some of the symptoms that I've, seen patients for as well, is things like headache,
Right.
or pressure.
Right.
Is anything else beside? Because again, like you said, it's a silent killer.
Right.
So at some point, it's going to reach a level that would
Absolutely.
be it.
Absolutely. So people might get blurred vision. People might find that when they walk, they get short of breath or get chest heaviness or tightness, severe headaches. You can develop severe kidney damage from uncontrolled high blood pressure, and that can cause you to become fatigued, have fluid accumulate, swelling of your feet, things like that. And you may never know it until it's real bad. And of course, we don't want it to get that far. So the monitoring is very, very important, in those circumstances.
So having really access to healthcare,
Access
to
to
a
healthcare.
physician to help at least monitor some of these things before they become a problem.
Absolutely.
Is extremely important.
And it's so simple. You come in, you get a blood sugar check to exclude diabetes. Your blood sugar is monitored. Your blood pressure is monitored. Your cholesterol is monitored. The doctor takes a good history. If we can switch over to talk about symptoms, perhaps.
Absolutely.
So many people don't know what to look for when they have symptoms related to heart disease. So let's talk about the most common thing, which is blocked heart arteries or coronary disease. So there are 3 arteries that bring blood to the heart. All these risk factors cause these arteries to narrow or plug up with cholesterol. And when that happens, the heart is a muscle. Blood may get to the heart muscle when you're sitting relaxing, but when you're doing something like a muscle anywhere, it requires more oxygen, more blood. And if your arteries are blocked, you may get the following symptoms: a pressure, heavy, tightness feeling in the chest. Not a sharp pinpoint pain, but a pressure or an uneasy feeling or something isn't just quite right. And it'll happen with exertion. So you'll go out to the mailbox every day, and then one day you go out and it's cold and it's snowing and you have this pressure feeling, and then you get back inside and it goes away. That's a warning. Those are things you have to recognize. You might get sick to your stomach, short of breath. Those are warning signs that you have to pay attention to. They come on and then they go away with rest. We ask people if they have chest pain, but pain is not what they have.
It's more of pressure.
Heavy,
Or
tight
heaviness.
pressure. Women, older people, diabetics, unfortunately, don't have the typical symptoms. So the key is, if you have something different occur when you're doing your usual activities, get on the phone, call your doctor, discuss it with them. The women are very good at that. The men are not. The men say, it's agita, it's this, it's that. I don't want to deal with it. And the next thing you know, a heart attack occurs.
Well, some guys are guys. I mean, we kind of go, I guess, on our genetic, upbringing, the way we really build. That's why we never ask for directions.
Right.
But we always think that we're right. And sometimes, and a lot of times, we're not right. We're sometimes wrong. So you do have to kind of really put it in perspective. And even if a family member sees something different with you, you're sweating more, that you're doing regular activities, you just look different, you're complaining more.
Right.
And you say, well, it's indigestion. That's something that's always sort of talked about, heart
Right.
disease versus indigestion. And they're very different.
Very different. You don't want to ignore it. I always tell my patients, and this occurs every day in patients that I've put stents in and treated for heart attacks already. They'll be home and they'll have symptoms for days and a week and never call for various reasons. Pick up the phone, have the discussion. Often it can be handled on the phone, or we can guide you. We can say, come on in. We can say, don't worry. We can say, go to the emergency room. But have the discussion early.
Let's say they do see their cardiologist. It comes in, they do have some symptoms. How do you initially treat it? No, let's say you already know that is the case.
Right. So if people have blocked heart arteries, coronary disease, angina, there are certain medications that we know prevent death and help them. And one is the beautiful little baby aspirin. A baby aspirin, anybody with risk factors needs to take. Anybody with risk factors for heart disease. That prevents heart attacks and death. It makes heart attacks smaller. The statin drugs, everybody who has that problem should be on a statin drug if they can tolerate it. And then there are medicines called beta blockers, and they're blood pressure medicines and heart medicines that block adrenaline and lower blood pressure. So when you exert yourself, the work of the heart is decreased. The blood pressure doesn't go as high, the heart rate doesn't go as high. Those are the three classes of medicines that we try to use as much as we can because we know the benefit.
And if it does work for the individual, obviously that's kind of where you stop at that point. You continue to monitor the patient. When do you go further? Let's say you have to do something like you mentioned, stenting,
right,
or bypass. How
right.
do you govern that?
So we've come to learn that, there are, let's say, 3 categories of patients, or 4. There are people without symptoms who unfortunately don't have a warning system. Again, very commonly the elderly, very commonly diabetics, and it's very hard for them to monitor because they don't have symptoms when they develop a problem. Then there are people with mild symptoms, moderate, and severe. So mild symptoms might be, you might be able to walk the golf course. And when you go up the last hole on a hill, you get a little bit of angina. You stop, it goes away. You get that all the time. That's mild and stable. So if things are mild and stable, we treat them with medicine. As they get worse and worse, for example, let's say now you get that chest discomfort when you're walking from the car to the first tee, and you never had that before. That's a change in your status. That could be a change in the level of blockage in your arteries. You need to get your doctor and say, this is happening. So when it gets worse and worse, we know that you might benefit from a procedure such as an angioplasty with a stent or an open heart operation. Not everybody needs that. We're also able to identify people that have abnormal stress tests, and we're able to stratify them into different classes to decide whether they need medicine or surgery. Again, a very abnormal stress test, a stress test being a test where people get on a treadmill, we raise it and speed it up every 3 minutes. If they go for a long time before getting symptoms or findings on the test, we know that we can treat them with medicine as long as their clinical status doesn't change. If their stress test is very bad, we know that they're imminently at risk for a problem. We recommend doing an angiogram or a heart catheterization and possibly a stent or a bypass.
So now you're kind of touching a little bit about the different type of tests that
Right.
are done on it. And because it's in the discussion within itself, which I like to touch upon a different test that you can do for the heart
Sure.
to make that determination. I want to take maybe just a quick short break and then we'll really start discussing that.
Excellent.
So what we'll do is we'll take a short break, we'll come right back, and what we'll talk about is the different tests that can be done to assess your heart and then determine, are you a candidate for just medications versus angioplasty or stenting your heart, or do you need something major like a bypass surgery? Stay tuned. This is Your Healthcare. We'll be right back with Dr. Cliff Kramer. Welcome back to Your Healthcare. We're here discussing your heart, one of the most important things that you need to know. And we're here with Dr. Cliff Kramer discussing some of the risk factors, some of the things you need to know about keeping your heart healthy. Dr. Kramer, once again, thank you very much for being with us. I think this is a very important show for the audience here. And what we started talking about the last segment is really some of the tests that are out there. Echocardiogram, EKGs, stress tests. And how do you sort of decipher when you do certain tests?
This is a huge area that's very, very important. And what I'd like to start with is the purpose of a test or the purpose of a stress test. Because many people come to us, take a typical 40 or 50-year-old man, maybe he hasn't seen his doctor, maybe he wants to start exercising, and he says to his doctor, I think I should have a stress test. And his doctor orders a stress test. So he has no symptoms, he feels well, and let's say he has no risk factors. So what you're doing is a test on somebody that does not have a high pre-test likelihood of having a problem or the disease. So the problem with that is that very often we do tests and we end up with some abnormality and we have to figure out what to do with that abnormality on the test. These tests are not perfect. So you have this test and I might see a little something on the test and then start recommending further testing when I really find out that you have no problem. I don't want to start testing you unless you have a high pre-test likelihood of the disease.
Because you want to really eliminate the false positives.
You want to eliminate the false positives. And what we mean by false positive is an abnormal, falsely abnormal test for the audience.
When you really don't have an underlying problem.
You don't have an underlying problem. It would be like somebody coming in and saying, I'm 60 years old, I've never been sick, can you do a CAT scan of my body? It's the same thing. And the answer is no, because we're going to find all kinds of little things, and then we're going to start looking for more things, and then you're going to have procedures, and we don't want to do that. So if you come to me and you don't have any risk factors, or you do have some risk factors, but you don't have any symptoms, and you exercise, we don't need to do something called a stress test. There's a certain population of people that might benefit from further testing. I'll use you as an example. Let's say you're the picture of health. Let's say you're 40 years old and your cholesterol's high. So it's 150 or 160. And you want to know, Cliff, should I take one of these statin drugs? What you really want to know is, do you have blocked heart arteries and do you need statin drugs to prevent a problem? So, in that circumstance, I might treat you with a statin drug if I found that you had a problem. And there are certain tests, it's actually a CAT scan to look for calcium in the coronary arteries. But it doesn't tell me whether you have bad blockages in the arteries, just that you have some blockage. So that might change your risk factor profile, and I might treat a young man like yourself with a statin drug and a baby aspirin if I found that. But in general, if I have a person who's in his 70s and he has diabetes and high blood pressure and he's got several risk factors, I'm going to treat him with a statin drug to lower it. If he's not having symptoms, I'm not going to fix him. So the stress test isn't really going to help me. I want to do that if I have a good reason for it. So that's one of the tests. And these tests are done with imaging, with nuclear imaging, with ultrasounds of the heart, to help sort of improve the diagnostic accuracy. But it's a lot of money. You're minimally exposed to radiation. We want to have a good reason to do these tests.
So what about the standard test you have, an EKG or ECG in your office? A lot of primary care physicians, you come in, they do an EKG.
Well, it's the standard routine physical for a healthy adult male is seemingly going out of favor, as well as an EKG. It's very unlikely that having a yearly EKG is going to be useful. Now, in my practice, I'm a cardiologist, so I'm seeing heart patients every day. If your general doctor knows you have a heart problem, he wants to do an EKG every year. That's different. But if you're young, if you're healthy, if you have no problems, the standard EKG, again, unless there's a symptom or a change in your status, it's not that important or reliable a test. It doesn't give you that much information. Now, it's simple, it's benign, it's non-invasive, it's cheap. It's not a big deal. But the exercise EKG, that's EKG that's done during the stress test, gives us more information if we think we need that.
And what about an echocardiogram?
An echocardiogram is a simple test. It's an ultrasound test. It's not invasive. And basically, a technician puts some jelly over your heart region and bounces sound waves off the heart and is able to tell us the status of your heart valves and your heart muscle. And that's a very useful test under the right circumstances. So if somebody has heart failure, we didn't talk about heart failure, but heart failure is the inability of the heart to pump blood to the body effectively because it's weak. Or if the heart suffers from high blood pressure, it's unable to accept the blood as it comes in, and it causes symptoms of breathlessness. People with heart failure can't breathe when they lie down, when they walk, they wake up short of breath, they have swelling, they have coughing at night. The echocardiogram gives us an assessment of their heart valves and heart function, and we're able to treat them and tailor our treatment. So somebody with a heart problem, we always want to know what we call the ejection fraction, or the status of their heart muscle, or how effectively it's squeezing each time it beats.
So how good it is to kind of get the blood out of the heart to the body.
Yep, and also to assess how the heart's doing when blood comes in.
And one thing I also want to touch on, and actually it's a very complete discussion of just the tests that are out there,
right,
is some of these blood thinners.
Yes.
And really for the audience, before we're done with the show, I'm going to give you a really up-to-date of something coming down the pipelines that can actually save lives really into the future. It's kind of more the cutting edge of where some of this medicine for cardiology is. So stay tuned for that. But let's just touch upon things like the Coumadin, the warfarin, the heparin, the aspirin.
Right.
How do you and some of these new other drugs,
right,
Daxa and so forth.
Right.
How do you choose when to put some of these patients on these type of drugs?
A good question. So let's break it down into antiplatelet agents, and those things, that's what an aspirin is. Plavix or clopidogrel or Brilinta. These are medications that many heart patients take. When we put stents in, these are metal little cages that we put in the heart, clear out the arteries. They attract blood clots. We don't want that, so we give people aspirin, Plavix, or Prasugrel, or clopidogrel are the generic names. So that's an agent that we use for antiplatelets. The platelets cause blood to clot. This prevents them from clotting too much. So that's one class of drugs that's very useful and very important. And of course the flip side is that they can cause bleeding, so we have to monitor for that. And we use that mostly for the blocked arteries, people with blocked arteries in their legs, their neck, things like that. There's another very common condition that we didn't talk about is atrial fibrillation. And for atrial fibrillation, we use either aspirin or these anticoagulants. And the anticoagulants are different because they're not antiplatelet agents, they're anticoagulants. They act differently. Coumadin is one of them. And then there's a new class of drugs. We call them new oral anticoagulants, or those of us in the profession, NOACs we call them. And the bottom line is that they're equally effective, but there are some reasons to use one or the other. And they're strong blood thinners that we use when we think it's necessary to prevent blood clots. And sometimes we use them in combination with the antiplatelet agents. Coumadin has to be tested. You have to avoid certain leafy foods if you take it. You have to go for blood tests a lot. The other pills, you don't have to adjust your diet, and you don't need blood tests. And there are certain circumstances where you can use some and not others. And it's a growing field, it's changing. We have new medicines coming out, some that might actually be better than the ones we have, but that's sort of the overview.
And you mentioned atrial fibrillation, that's an irregular heartbeat.
Exactly.
Right, usually your heart goes 1, 2, 1, 2, but this is sort of 1, 2, 1, 2, 1, 2, 1, 2, 1, 2.
Exactly.
So that's when you get more prone to having such a clot occur in your heart because it's not contracting well.
Exactly.
And now let's go a little bit more invasive.
Yes.
So you mentioned the stents. Now there are different type of stents, metal
Right.
back stents and those that are not.
Right.
And also, let's say, bypass surgery.
Right.
When would you say you're not a candidate for a stent, let's say, because you know that there's some clogging of the arteries.
Sure.
You can have that, or you need really a bypass surgery all the way to a heart transplant.
So people that require further investigation of their problem have what we call a coronary angiogram or a heart catheterization. So I would bring you into a laboratory, put a little tube in through your wrist or your leg, snake tubes up to the heart, take pictures with dye, and I get to see how badly the arteries are blocked, how many are blocked, where they're blocked. And basically, if it's a good situation for an angioplasty or a stent, I would then thread a little tube with a balloon on it over a wire across the blockage. The balloon has a stent around it. It's kind of like a scaffolding around the balloon. I blow the balloon up, the stent stays inside, the artery clears out, and we're done. And we can do this for 1 to 2 to 3 or more arteries. So that's preferable, of course. It's done in one day, you go home the next day. Generally, these things hold up very well.
And how do you choose the type of stent that you use?
There are 2 types of stents. A new one is being studied, but we'll talk about the ones that are around. And we call them bare metal stents or coated stents or drug-eluting stents. So that bare metal stents don't have a coating, The drug-eluting stents have a chemotherapy coating on them. And the purpose of that is when we blow up the balloon, the stent attaches to the inside of the wall. This whole process injures the wall of the artery. And when you injure anything in the body, it heals. And sometimes the healing process can grow through the stent. So this chemotherapy agent leaches out only into that local area, and it kills off some of these healing cells to make it a less aggressive healing process, and it doesn't narrow in. So we generally use those pretty, majority of the time. Sometimes if the arteries are very big and they're not likely to re-narrow, we use the bare metal stents. Or sometimes if people aren't going to take their medications, we don't know that they're going to be compliant, we don't use the drug-eluting stents because it requires more intense antiplatelet therapy. So if the stents can't be put in technically, or if there are so many arteries blocked, or if you're a diabetic and have a weak heart with a lot of arteries blocked, that's the approach. Otherwise, you get the open heart operation. And that's what we call a bypass or a coronary bypass, or, it's a form of open heart operation, which is a more invasive procedure, but very successful. So it takes a longer recovery. The sternum has to be split, the chest open. You're in the hospital for 4 or 5 days. The recovery is a month or two, but it's very effective and these days very safe.
So for an open heart surgery, if you end up being that type of candidate,
right,
essentially you bypass the blocked artery. You don't replace the artery. You essentially form a different route for the blood to go.
Exactly. So you'll hook up an artery or a vein to the aorta and then hook the other end of it past the blockage. So you're bypassing the blockage. The blood pumps into the artery past the blockage and feeds the heart muscle.
And for sake of time, I just also want to touch on congestive heart failure.
Right.
Where it's not pumping as well, you're retaining fluid in your body and so forth.
Right.
That's a little bit different than a different way that your heart's not functioning well.
Right.
For that, use other type of medications to help with fluid. You don't want fluid overload on your heart.
Exactly. So there are several medications that we use for that, and they're different classes of medications, and they're basically ACE inhibitors, which is a kind of blood pressure medicine that helps the heart function effectively. There are beta blockers. We want people to be on those. We also often need them to be on a diuretic to reduce the fluid overload.
A water pill.
A water pill. And there's another, type of diuretic as well, depending on the status of the heart. So we're looking to get you free of symptoms, free of swelling, free of breathing trouble when you're lying down at night, so that you can walk the golf course, you do the things you want to do.
And that's important.
Very. Our goal is to make you better, have you function.
Absolutely. That's where we're here, to make your life better. And for the last couple of minutes before our conclusion, I did want to say there is something, we spoke about some of these blood thinning type of medications, and there is something coming down the pipeline. It's not out yet, and this is sort of really the upfront state of the art that's going to be out there, and it's actually more of an antibody against thrombin. It's a different type of medication that's going to be there that will protect your heart without increasing your chance for bleeding. So unlike anything else that we have now out there, any of these blood thinners essentially increases your chance of bleeding. This new medication is going to be coming out. We don't know when. It's still under investigation now. But it's a chance that when it comes out, it can save lives, it can save your heart, and it can save you against strokes. You can take this medication without increased chance for bleeding. And you heard it here on Your Healthcare with Dr. Cliff Kramer and myself, Dr. Amit Lahav. Stay tuned. We'll conclude in just a moment about your heart. Welcome back to Your Healthcare. I'm Dr. Amit Lahav, and today we had a very informative show about one of the most important parts of your body, your heart, which keeps you alive every day of your life and starts beating before you're even born to the day before you're no longer with us. And we want to really prolong that time. And we had a discussion with Dr. Cliff Kramer, cardiologist, about all the risk factors and things that you can do to make your heart last longer. Heart healthy, that's what we need. Anything from diet, eating appropriately, maintaining a good body mass index or a body weight, exercising appropriately in the right exercises you do, really maintaining good glucose level, maintaining good control of your diabetes, and really being aware of what your body is, high blood pressure, how your heart is doing, symptoms. Those are the things and risk factors you have to take in mind to really maintain a good, healthy heart. And that will give you the prosperity and longevity that you want. Thank you for watching. I'm Dr. Amit Lahav here with Dr. Cliff Kramer discussing your heart on the show Your Healthcare. We'll see you next time.